Assalamu alaikum again. I am Muhammad Nazal. I am the coordinator of Just CRS program and project. Just CRS is a program and project that is co-funded by the Erasmus Plus program of the European Union. This webinar is part of the activities of this program and is brought to you by generous support from the EU. Also, it's brought to you courtesy of Maharat platform, which is a new free platform, e-learning platform from Jordan University of Science and Technology. And we are so delighted to for you to have this presentation. We are delighted today to have this last webinar of the series, Sleep Disturbances and Fatigue, the role of neurorehabilitation specialists. And we are very delighted to have Dr. Ilham Al-Shurman, the assistant professor in physical therapy program at Jordan University of Science and Technology. We also so delighted to have Dr. Mais Ad-Dughmi, the assistant professor on the Department of Physiotherapy in the School of Rehabilitation Sciences in the University of Jordan. We will start right now. If you have questions, please write it down in the chat area. So thank you for attending, and let's start.
Okay, thank you, Dr. Nazal, for hosting our presentation and your introduction. As Dr. Nazal mentioned, our topic for this presentation is about two important factors, sleep disturbances and fatigue, and what is your role as neurorehabilitation specialists. I'll be presenting, and I'm an assistant professor in the physiotherapy department at the School of Rehabilitation Sciences at the University of Jordan. And this presentation will also be presented by my colleague, Dr. Ilham Al-Shurman, and she will start this presentation and give it a go.
Thank you, Dr. Mais, and thank you, Dr. Muhammad Nazal, for giving us the chance to present here for our great audience. It's really our pleasure today to be here, me and Dr. Mais. And for who don't know me, again, Dr. Muhammad presents us. My name is Ilham Al-Shurman. I am an assistant professor in the Physical Therapy Department of Rehabilitation Sciences at Just University. And it's really a pleasure today to present about our topic today, which is the role of sleep disturbances and fatigue, highlighting the role of rehabilitation specialists. And as you know, during our rehabilitation session, PT and OT plan activity-focused intervention that emphasize the need for practice and repetition of motor action, and that be in challenging environment. Therefore, physical therapists and occupational therapists frequently spend large portion of their treatment session teaching patients how to perform these tasks in order to improve a given impairment and to increase the independence of their daily living. Therefore, we believe that focusing on an understanding or exploring factors that are important for motor learning, for enhancing the way the patient learn from us the motor task is very important. And from our notice, and you might see yourself in the clinic, in rehabilitation clinic, we usually mostly focus on the motor impairment of the task. So usually we focus on the motor aspect of any impairment. However, without any intention, we ignore the non-motor aspect. However, over the past decade, a growing body of evidence has demonstrated that non-motor factors are also important for motor learning and rehabilitation specialists. Here in our presentation, me and Dr. Mais will highlight two important factors that are sleep disturbances and fatigue. Therefore, the focus of this course will be to provide a neurorehabilitation specialist with practical knowledge about the importance of assessing and addressing sleep issues and fatigue within their patient. And also we will try to cover a review of literature on why sleep and fatigue are very important components of promotion, rehabilitation, and prevention. So our presentation will cover the following topics. We will try to cover an overview about sleep, also important of sleep for our body function. We will mention and highlight sleep disturbances among people with various neurological conditions, which is very important. We will shift our thinking after that into fatigue, and we will do the same overview about fatigue, prevalence of fatigue among neurological condition. Then we will come to the most important thing, how to assess sleep and manage sleep, and how to assess fatigue and manage fatigue. And here we go. We will start with sleep. We all love sleep. We all need sleep. We all fight for sleep. It is a basic human need for survival. And based on the pattern of electrical activity in the brain measured using electroencephalogram, eye movement measured using electrooculogram, and muscle tone measured using electromyography, sleep has been defined by 4 behaviors. These are reduced motor activity. So during sleep, there is no motor activities. There is a decreased response to stimulation, and also we adapt a stereotypic posture. Usually it's a lying down and supine position. Also, the last feature is sleep is relatively easy to be reversible. Supposed to be, we can get easy to awake state, and this is very important to differentiate that from other brain states such as coma. Also, sleep cannot be considered as a homogeneous state. Instead, it has been broadly divided into 2 different stages and named according to its main distinctive feature. The first phase is called non-rapid eye movement, and usually we say non-REM sleep. And according to the recent American Academy of Sleep Medicine scoring manual, non-REM sleep is divided also into 3 characteristic stages, and that corresponding to increasing the depth of sleep. Whereas stage 1, it's about the transition from wakefulness into sleep, and it corresponds to light sleep, where we start the in and out from our surrounding environment. Usually we start to have hallucination in this stage. Stage 2, it consists of brain waves, specifically sleep spindles and K complexes. And as the sleep deepen, there is increase in slow wave sleep, our slow wave activities, which is delta activities. We call this stage slow wave sleep. On the other hand, rapid eye movement, it's the second stage. It's characterized by muscular atonia, and that's global muscular atonia, despite the rapid eye movement. And you can, if you see person who is in REM sleep or this stage, you feel that he is awake because he has a lot of eye blinking. And I want you to see here the brain activity during REM sleep and during the awake period. As you can see here, there is a comparable activity between the 2 stages or the 2 brain stages. And in the awake period, beta activity are abundant. Also in the REM sleep, beta activity is abundant. So from here, we start to think why brain is so active during REM sleep. What's going on in the sleep? What's the function of sleep to be for the brain to be active as much as the awake state? So a lot of questions come to our mind when we think about sleep. So during the night of sleep, young adults have a specific pattern of sleep stages. Young adults enter sleep by through non-REM sleep, and that followed by REM sleep. So usually we start from stage 1, stage 2, and slow wave sleep, and then REM sleep, and going back to stage 2. If you go back to stage 1, this is a bad thing because it's a shallow sleep. You feel you wake up at that moment. So as the figure show, we go REM sleep, stage 1, 2 is slow wave sleep, and then REM sleep. These stages alternate in a cyclic manner every 90 to 110 minutes, and these cycles happen 4 to 6 times. If you do simple calculation, you can guess the perfect sleep timing you need to get every night to have good sleep quality. We will talk about this in a moment. Also, the interesting thing about the sleep is that the ratio between non-REM sleep and REM sleep change during sleep, where you will have during the first half of the night, most of your sleep is slow wave sleep. And if you remember, if you are focused with me in this presentation, as I mentioned, slow wave sleep is the deepest sleep where you can really feel you got a deep sleep. So this happened during the first night or the first 3-4 hours of your sleep. On the second half of the night, the stages that are prevalent are stage 2 and REM sleep. And again, I want you to remember that REM sleep is a stage where the brain activity is increased. So it's something interesting about sleep. Also, studies try to understand the brain activity during the sleep. Functional brain imaging has been used in a human to characterize the pattern of brain activity that is associated with REM and non-REM sleep. And as you can see in these figures, REM and non-REM sleep, there is a difference, whereas the brain is much active, looking at the red color, much active during the REM sleep compared with a non-REM sleep. So a consistent finding that came up from PET and functional MRI is that always there is a reduction in brain activity during non-REM sleep, and that reduction occurs in subcortical and cortical region. And that might explain the restorative function of sleep need for energy recovery. On the other hand, a totally different story, pattern of brain activity associated with REM sleep are considerably different from non-REM sleep. However, it's not different from the pattern associated with wakefulness. So many regions increase their activity during REM sleep, as I mentioned in the previous figure. The question, how much sleep do I need? It's from person to person different, but everybody try for more. However, it is different across the lifespan. But however, the recommendation from the National Sleep Foundation is the following: 7 to 9 hours per night is enough for a person who is from 18 to 64 years old. Less than this, like 6 hours, more than this, like 10 hours, it might be appropriate, but the most recommended hours are 7 to 9. Go back to the calculation that I asked you to make. I mentioned like 90 minutes of sleep stage 4 times to 6 times. If you calculate that, you will find like 7 to 9 hours is appropriate to go through these cycles all the night. All right. The question again, how many hours I need to sleep? Another confusing question is what's the importance of sleep? And a sleep pioneer researcher who is Dr. Allen, he once said, if sleep doesn't serve an absolutely vital function, then it is the biggest mistake we ever made in our life. From here, researchers start to think about about the function of sleep that might have other than recovery. We all know that sleep let us have our energy recovery. However, it's not enough for a big state that the brain have 7 to 9 hours the whole life. So it's a hot topic right now, searching about the function of sleep. Dr. Mace will go through the most important function that linked to sleep for our body function. Dr. Mace?
Yes, thank you, Dr. And speaking after the physiology of sleep, as Dr. Inham mentioned, that Dr. Allen, who's a pioneer in sleep research, said it's a vital function. It's definitely a vital function because it has been shown that sleep plays a major role in the proper functioning of various body systems. When you think about sleep, it's the time where your brain recharges itself, your body cells repair themselves, and there will be a secretion of a lot of hormones that triggers various body systems and alarms your body that it's time to go to sleep. The various body systems that are important for proper functioning because of sleep include the immune function and tissue healing, pain modulation. We see that sleep is important for cardiovascular health, for cognitive function, and most importantly, it has been shown that it is important for learning new skills. Next, please. So if you look closely at each body function and see what's the role of sleep in it. If we look at immune function and tissue healing, several studies that explored sleep deprivation has shown that those who are sleep deprived, meaning that they do not have enough sleep, they have changes in their immune response. Physiologically, the changes that can happen is an overproduction of pro-inflammatory cytokines. Sometimes there is even an altered activation of stress systems like the sympathetic nervous system and the hypothalamic pituitary adrenal axis. There is also modulation of certain formation of immune cells. All these changes, unfortunately, might decrease the ability to fight off illnesses effectively and definitely alters the body's tissue healing mechanisms. So if you think about it in terms of your patients, especially if you see your patients having several injuries and those diseases that are, for example, autoimmune, definitely if they are sleep deprived, they will have problems with their tissue healing and the ability of their body to fight infections. And in speaking of immunity, it is worth to mention under the uncertain circumstances that the world is going through right now, which is the COVID-19 pandemic, it is very important and crucial to have a really good night's sleep. So to help your body fight off COVID-19. It might not treat it, but it will definitely fight it. When it comes to pain and sleep, both of these factors have a reciprocal relationship, meaning that, for example, if your patient has deprived sleep or poor sleep quality, their pain will increase in terms of its sensitivity and intensity, and vice versa. So if they have a lot of pain during the night, they will not have a good night's sleep and eventually have poor sleep quality. And this relationship between these two factors is believed because they're both controlled by similar neural mechanisms, mainly through central serotonergic neurotransmission. Now, if you look at the research done on pain, there has been a lot of evidence that links pain with poor sleep quality in conditions that have chronic pain. For example, patients with fibromyalgia, those with osteoarthritis, low back pain, painful diabetic peripheral neuropathy, and definitely progressive neurologic conditions, especially in the acute stage after an insult or an injury. Like, for example, traumatic brain injury patients during the acute stage after they encountered a traumatic event, they will have a lot of pain that unfortunately will cause poor sleep quality. So therefore, as you can see, sleep quality is very important in modulating pain perception and definitely should be part of your assessment and your management plan when you want to treat pain in your patients. If you look at cardiovascular health, most of the research done in this area focused on the effect of sleep duration on various cardiovascular diseases, whether it increases the risk or not. So they divided the sleep duration into either long or short. So when we say that somebody sleeps at long duration, we're talking about more than the recommended hours, 8 to 9 or even 10 hours per night. We will see that those that sleep this long will have an increased risk of developing cardiovascular diseases along their lives, and even increased risk, unfortunately, of mortality. The same applies for those that are short sleepers or usually sleep less than 5 to 6 hours per night. Those individuals will have an increased risk of developing or even dying from various coronary heart diseases. Now, the exact mechanisms behind why sleep quality affects cardiovascular health is probably mostly unknown. However, different theories includes that probably the increased sympathetic nervous system activation due to sleep deprivation that causes fluctuations and variability in the heart rate and blood pressure might cause these unfortunate changes in somebody's cardiovascular health. Sometimes also the presence of other factors that might disrupt sleep and also increase the risk of cardiovascular health, like psychological problems like depression and anxiety. Also, another important factor is the presence of a sleep disorder. When somebody is diagnosed with a sleep disorder, like for example, obstructive sleep apnea, it definitely increases the risk of developing various cardiovascular diseases like ischemic heart disease, arrhythmias, and even strokes. Another important factor that might be affected with sleep is the psychological well-being of individuals. We all know how a lot of chronic neurological conditions, unfortunately, suffer from psychological issues like depression and anxiety. Unfortunately, if they do not sleep well as well, this will increase because if you look physiologically at the mechanisms behind this, those who are sleep deprived or even have general sleep disturbances have alterations in the regulation of neurotransmitters that are necessary for our emotional and psychological well-being. There will be also hyperarousal of areas of the brain that are related to emotional regulation. In fact, 75% of people who are depressed have experienced symptoms of insomnia, which is a sleep disorder that we will touch base in the following slides. Another important function that might be affected by poor sleep quality and is actually relevant a lot to neurorehabilitation is the cognitive function. Sleep disruption can definitely impact your patient's ability to perform cognitive functions that are necessary for various rehabilitative treatment plans. If you think about it as a PT or an OT, you incorporate a lot of treatments in your rehabilitation that requires the patient's function of different cognitive domains. For example, you want your patient to sustain attention while you're giving him instructions and for a task that requires focus. For example, we use a lot of tasks that requires the ability of the patient to switch their attention between two different tasks, which is dual tasking. The ability also to focus on pertinent stimuli while dismissing impertinent stimuli. So for example, if you're doing your session with your patient in a hospital setting, where there is a lot of distracting surroundings and noise, you want your patient to focus with you. Also, the high cortical cognitive functions like problem solving, decision making, and goal directed tasks. So definitely we see that those who are sleep deprived will unfortunately have slowing of their responses. They might have an increased tendency to make mistakes on attentional tasks, and unfortunately it might also lead to a decline in auditory and visual spatial attention and working memory, further affecting let's say the rehabilitation process and even participation in therapy. Also, another important factor that unfortunately will be affected by having poor sleep quality is also a relevant factor in neurorehabilitation, which is motor skill learning. Several studies have explored the effect of sleep deprivation and poor sleep quality on the performance of different motor tasks. And those studies have found that those who are sleep deprived will have, unfortunately, affect their learning in various tasks. Tasks as simple as finger tapping using computer-based tasks, or even complex tasks and functional as walking and arm reaching might might also unfortunately be affected by having poor sleep quality. Now, Dr. Ilham will highlight this point by discussing a recent published study on motor skill learning and its effect on sleep, and then we'll move on forward with this presentation. Dr. Ilham?
All right. Thank you so much. So as Dr. Mais mentioned, in addition to the most important function that sleep have, we have a very important function that linked to our profession, to our rehabilitation session, which is motor skill learning. So studies have found that different motor tasks have been shown to benefit from sleep to enhance learning, and that varies from simple to more complex tasks such as functional tasks. And before going into our research, current research that's trying to prove this idea, I would like to just review the formation of memory, motor memory, how our brain form motor memory. And as you might know, memory formation appears to develop over time in different stages. We start with the encoding stage. The encoding stage, or we can call it the acquisition stage or the online stage. It means, or it describes the initial engagement with an object or performance of an action. Now, successful acquisition results in attaining a certain level of task proficiency and also lead to rapid formation of a memory representation in the brain. So it's very important. Now, from encoding, we go to the second stage, which is the consolidation stage, and we call it offline motor learning. And offline motor learning or memory consolidation refers to the conversion of memory traces from liable state, where we can lose them, into permanent state or permanent state in the brain. The third stage is called storage, where we keep our memory inside our brain, and we can recall it back in the fourth stage, and we call it for another use. So now, what's the role of sleep in this memory formation, motor memory formation? Sleep has been found to impact each stage of procedural memory formation. However, the consolidation phase is the most thoroughly studied stage with regard to sleep, with most of the study have conferred the beneficial role of sleep on procedural memory consolidation. And what does that mean? So if you have a subject today, if you have a patient today, and you practice with him a specific task, if this individual sleep following practice a motor task, he will perform better on the task compared with individual who stay awake for a similar period of time. So no practice during this period, however, there is improvement. This is what we call sleep-dependent offline motor learning. There is an enhancement for the practice for the task performance happened during the sleeping time. This has been improved in the young older adults, and also sleep has been shown to enhance motor learning in individuals with a chronic stroke and individual with multiple sclerosis. Now, again, we're back to our figure. Our research proved that sleep is good for consolidation, and a recently conducted research in Jordan University of Science and Technology, we recently found that sleep also enhances motor learning online. So sleep is important for consolidation, and our research also proved that sleep is important for the encoding phase, which I believe it is very important phase for having the task, the motor learning. So we performed two different studies, one to assess if sleep impact or sleep quality impacts the encoding phase in MS individual, and the second study was to examine that on BD individual Parkinson disease. So the participants come to our laboratory at Jordan University of Science and Technology, and we ask our participants to practice a novel task. We ask them to play a game, novel game, using virtual reality system that has been developed by our research team in a previous study. So it depends on the participant, if PD or MS. We need as a research team decide which game is appropriate for this group of patients and decide the game. After that, we ask the participants to practice this game for a specific time, for a specific blocks. If you see in this figure, there is an example. There is examples of the developed game. So we decide one of these games for the participant to practice. After that, we calculated the motor performance, the online acquisition, and we correlate that with the sleep quality. And these are our results from the current studies. We found correlation between motor skill acquisition and subjective sleep quality in MS, and also between motor skill acquisition and subjective sleep quality in Parkinson's disease. So sleep quality affects motor skill acquisition in people with BD and MS as consolidation phase. So now we highlight that sleep is important for our body function. We understand sleep more, and as we know, our presentation today to highlight what's going in a neurological condition. So in coming slides, I will focus on sleep in neurological condition. And what we know that sleep frequently altered in individuals with a neurological condition who are likely to receive rehabilitation services from us, such as a stroke, Parkinson's disease, Alzheimer's disease, multiple sclerosis, and TBI. So poor sleep quality affect their ability to learn and potentially influence recovery and their overall quality of life. So starting with multiple sclerosis, 50% of MS individuals have sleep disorder, most commonly insomnia, which is a sleep disorder characterized by inability to initiate sleep. And if we can initiate, we cannot maintain. We wake up in the middle of the night and we cannot maintain our sleep. They also have obstructive sleep apnea and have restless leg syndrome, which is an unpleasant feeling in the limbs. It makes the patient need to move urgently. And they have also narcolepsy, which is an excessive sleep disorder that's characterized by excessive sleepiness during the daytime. So suddenly the patient or the person feel that he is sleepy, or suddenly you can look at person who fall asleep without any even notice. So that's the condition that MS people have. Regarding insomnia, studies have shown that nocturia and depression are the main reason for this condition. And also because restless leg syndrome disrupts sleep, studies have found that it leads to excessive daytime sleepiness, depression, and again, insomnia and fatigue. For stroke, post-stroke, mostly there is a sleep-related breathing disturbances. Specifically in the acute stage of a stroke, most commonly obstructive sleep apnea. They also might have hypersomnia, which is waking up more than 24 hours, excessive daytime sleepiness, and they also develop restless leg syndrome. For traumatic brain injury, 50% of TBI have some form of sleep disorder, and that, as the studies shown, linked to other comorbidities that present in TBI, such as depression and anxiety, pain, and cognitive deficit. They might have insomnia, which is most commonly diagnosed sleep disorder, hypersomnia, obstructive sleep apnea, and again, narcolepsy. For Parkinson's disease, interestingly, 80% of those people have sleep disorder, such as insomnia, obstructive sleep apnea, and restless leg syndrome. It is totally associated with their poor quality of life. It increases their risk of falling, impulsive behavior, and lead to poor driving performance. So we talked about if you have a neurological disorder, how your sleep will change, how sleep is altered during the disease. It's a secondary complication of the disease. However, it's interesting finding that even sleep might predispose a disease. What we mean by that, if you have a chronic insufficient sleep, or if you have, for example, obstructive sleep apnea or insomnia diagnosed as a diagnosed disorder, that might contribute to development of certain condition, neurological condition. So evidence suggests that poor sleep may play an important role in the accumulation of beta amyloid, which is lead to development of Alzheimer's disease. Also, certain sleep disorders have been found to be associated with the development of Parkinson's disease and other neurodegenerative disease. So it's not only, it is a complication of having a neurological disease, it's also predisposed having another neurological disorder. So now we know the importance of sleep, and we know how sleep change or might lead to a neurological disorder. I want you to keep this information in your mind until Dr. Mais finish her overview about fatigue. Dr. Mais?
Thank you, Dr. Ilham. So now we will shift our focus into another important factor that affects neurorehabilitation of various neurological conditions, which is fatigue. Fatigue is considered a very complex symptom because it's multifactorial in nature. And there are a lot of definitions out there in the literature that attempt to try to define fatigue. But the most common definition that you will find out there is that fatigue is a subjective lack of physical or mental energy perceived by an individual that interferes with their usual and desired activity. And I highlighted physical and mental because it is very important to emphasize that fatigue is not only the physical exhaustion that your patient might experience, but also there is an important mental or a cognitive component that your patient will experience, as it also described as an overwhelming sense of tiredness, lack of energy, and feelings of exhaustions that's not only, again, physical, but also cognitive or mental. Now, if you look at the prevalence of fatigue among various neurological conditions that you would typically see in your clinic, we see that it affects a lot people with multiple sclerosis, patients with stroke, Parkinson's disease, and traumatic brain injury patients. If we look at how the acute versus chronic fatigue is, we see that it is not only acute, meaning related to the insult or the time of the injury or time of diagnosis, or associated with fatiguing tasks. When we define acute, I mean new occurring in the past 6 weeks. But also fatigue, unfortunately, can be a chronic condition that lasts longer than 6 weeks. So if we look at the etiology of fatigue, what causes fatigue? There are a lot of theories out there because the exact cause of fatigue in neurological conditions is unknown. Because it's very complex and believe it's a multidimensional phenomena. So fatigue might be caused by various factors. So for example, if we look at next, please, Dr. Ilham, fatigue might be caused by environmental factors, might caused by the underlying disease itself. So the disease processes might cause fatigue. Also, there are evidence relates peripheral control systems versus central control systems, and also environmental factors can cause fatigue. And I will explain a little bit more about these in a second. So if you look at the causes of fatigue, we can divide them into either primary or secondary. Primary factors are caused by the disease processes itself. For example, central nervous system mechanisms. If we take MS or multiple sclerosis as an example, the neuronal dysfunction that is caused by demyelination in patients with MS might cause their fatigue. If you look at other factors that are considered primary, like endocrine factors, abnormalities in the hypothalamic pituitary adrenal axes, and sometimes deficiencies in some growth hormones might cause fatigue. Also, neurotransmitter dysregulations like dopamine and Parkinson's disease patients. If you look at patients with stroke, the brain lesion, and the location of the brain lesion might be a factor that causes fatigue in these individuals. Low glasgow-coma scores at the time of the traumatic brain injury also has been linked to increased prevalence of fatigue in this population. And also, if your patient have pre-existing fatigue from other factors before, is also a contributing factor. The other classification is secondary factors, which are caused by the complications or the symptoms that accompanies the condition and might increase fatigue. So the physical deconditioning that we see in neurological patients, depending on if they have an increased disease severity or they are in the acute stage, for example, with a lot of pain, with a lot of psychological problems like depression and anxiety. And as you can see, I highlighted in red sleep dysfunction or disturbances are an important factor that unfortunately causes fatigue in these individuals. Also, we can see that cognitive impairments like slowed information processing speed and difficulty in concentration, and that's highlighting the mental component of fatigue. Demographic factors like older age, being a female, for example, and being unemployed are factors that have been shown that are highly associated with fatigue. The presence of other medical comorbidities, like if your patient, other than the neurological condition, have, for example, hypertension, have diabetes, have a liver disease, or a cancer patient, will also have, will increase their risk of developing fatigue. And also lifestyle factors, including a high BMI, for example, meaning being obese. Sometimes also there's studies that shown vitamin D deficiency is also linked with increases prevalence of fatigue in various neurological conditions. Now, if we look closely at the impact of fatigue on various neurological conditions, it definitely impacts their performance on various activities of daily living. It has been even linked to reduced employment rates, reduced social and psychosocial life, because basically they're just simply tired to engage with social activities. It affects their mood, definitely also highlighting how it affects their sleep quality and eventually their overall quality of life. It has been also associated with cognitive impairments and limitation in participation in various aspects, including therapy and rehabilitation. So overall, it might increase their disability. It is associated with their with a poor general health, and unfortunately even might increase the rate of healthcare utilization. So now to talk a little bit in more detail about the prevalence and the characterization of fatigue in various neurological conditions. So if we look at multiple sclerosis, it is the most common debilitating symptom in these individuals, affecting up to 90% of those patients. It is often even described by these patients a very severe symptom, even more severe than their gait difficulties and their balance problems. They classify fatigue in MS into two types. It's mainly either physical or motor, which is basically the muscle weakness, the slurred speech that they might have, their inability because of the general weakness they have to perform daily tasks. The other factor is cognitive fatigue, which is basically their deterioration to perform various cognitive tasks for a long period of time because basically they are mentally exhausted. So cognitive function and cognitive fatigue interrelate a lot, but they are a little bit different constructs if we understand the etiology behind the two. There are also other classifications of fatigue in MS. There is the term we use called fatigability. Fatigability is the increased weakness that comes along with performing a task over a long period of time. So for example, if they exercise for a long period of time, or as the day progresses, we will have increased weakness, and that's the term fatigability. It also applies for mental function. So if they perform, for example, an attentional task for a long period of time, for example, focusing on a lecture like this for 2 hours, might be mentally fatiguing for these individuals. Another term that is commonly used is lassitude, which is an abnormal, constant, persistent sense of tiredness. So another important factors to mention regarding MS-related fatigue is how distinctive it is compared to other conditions. What makes MS-related fatigue distinctive is that it occurs on a daily basis. It comes on easily and suddenly, so it is not, again, related to a fatiguing task. It comes on even when they are at rest. Usually it worsens as the day progresses, and research have shown that MS-related fatigue is worse in the afternoon compared to other times of the day. As you all know, MS individuals are sensitive to heat. So fatigue can be aggravated by heat and humidity. It is more severe compared to other conditions, and unfortunately, it interferes with their role performance and overall physical functioning. If you look at an evidence from a recent study, a recent published study by Dr. Ilham, she looked at the motor performance improvement and how fatigue affects that through a virtual reality task. And they have found that the motor performance of MS individuals on this virtual reality task is actually impacted by fatigue in a negative way, of course. So this definitely highlights the importance for healthcare professionals to be aware of the further negative impact fatigue can have on learning motor skills in these individuals. If you look at patients with stroke, fatigue in this population is described as a major yet neglected issue in these individuals because it can affect up to 70% of these patients. And it has actually been associated with lower rates of employment right after their stroke. It is different from the fatigue experienced in MS patients is that it does not change over time, but sometimes those who report fatigue at baseline show relatively higher levels of fatigue over time, but generally it does not change. Unfortunately, it has been associated with an increased mortality rates, poor functional outcomes and neurological recovery, low quality of life and participation in therapy in these individuals. What makes a stroke fatigue also different is the onset and its time course. We can classify fatigue in stroke patients into either happening in the acute stage, and when it's in the acute stage, it's actually normal because it's a normal response of their body from the neurological insult that happened. It's even sometimes described as being protective and restorative because it helps to protect them from further injury because they're feeling tired and probably they will just need to rest. So the risk of having other injuries decrease. However, when it becomes chronic and persistent, this is where it's pathological in nature and associated with complex etiologies. Primary post-stroke fatigue might be caused by attentional deficits that the patient go through in the specifically in the acute stage due to interruption of various neural networks like the reticular activating system. If you look at patients with traumatic brain injury, here the story is a little bit different. We all know that TBI patients go through complex and multifactorial symptoms. So fatigue in this population is morely subjective as it includes not only physical and cognitive components, but we see that the motivation and the situational and activity-related components affects and increases the prevalence of fatigue in these individuals. Many individuals with TBI actually tend to ignore the symptoms of fatigue, or even engage in compensatory strategies, like, for example, spending extended times in bed, or having daytime napping, or restricting participation and activities like a protective mechanism by ignoring this symptom. Usually fatigue in this population decreases in the first year following injury and remains unchanged in subsequent years, unless there are secondary factors that accompanies the disease and increase their fatigue. Usually fatigue in this population is related to situational stress and self-reported somatic symptoms. If we look at Parkinson's disease, also fatigue is prevalent in this condition, and it is mostly recognized as a non-motor symptom, and related to disease severity and progression. So as the disease progresses in Parkinson's disease patients, the more they will have fatigue. Usually there are contributing factors in this population, include being an elderly, being a male, having anxiety, more motor symptoms, having psychological problems like depression. The presence of sleep disorders further deteriorates their fatigue, and even as a side effect of medications. The reason or the etiology of fatigue in Parkinson's disease may be caused by mostly central factors or peripheral factors. We look at the altered activation of hypothalamic pituitary adrenal systems due to the inflammatory process and the stress that they go through. Central fatigue basically is linked to dopamine deficiency and can be even induced by decreased external stimulation by motor impairments. Peripheral fatigue, on the other hand, is, as the name implies, mostly peripheral, affecting the muscles itself, or physical or exercise fatigue. Sometimes they refer to it, that gets provoked by doing exercise or doing any sort of an activity, as the patient will sense this exhaustion by the repeated use of the muscles, either during any physical activity that they do. So to summarize what we have just talked about, me and Dr. Ilham, definitely we have showed you that sleep disturbances and fatigue are prevalent in various neurologic populations that are commonly treated by neurorehabilitation specialists in various clinical settings. It definitely may exacerbate their condition, slow recovery, affect their participation in therapy, and eventually impact their outcomes. So therefore, there should be a focus by therapists on integrating sleep health in wellness and health promotion interventions is warranted. And managing fatigue definitely should be a critical component in the neuro rehabilitation plan. So now, Dr. Ilham will take over and tell you about the sleep assessment and management.
All right, thank you. I hope nobody's sleepy yet, because this is the important part, how to assess sleep. Now, sleep assessment and fatigue assessment is very important, as we mentioned, for rehabilitation specialists. And before we start thinking about this topic, we asked ourselves a question. Is it worth to do this presentation and do like a promotion, or do to be sure that physical therapists have the knowledge? We don't know that. So we asked ourselves, do physical therapists and occupational therapists in Jordan recognize that sleep impact their outcomes? We really don't know. So we decided to do a research at JUST. We conducted a survey to assess the attitude of PT and OTs on perceived need to assess sleep of their patients. And these are the preliminary analysis for our result for our survey. We found an interesting finding. We found that 62.2% agree and 30% strongly agree that they should ask their patient about their sleep habit and sleep quality. We found like around 70 agree and 20% strongly agree that assessing my patient's sleep habit and quality is important. 70% agree and around 18% strongly agree that addressing sleep issues may impact physical therapy outcomes. However, only 11% respond yes to the question, do you routinely assess your patient's sleep habit or quality of sleep? So they on this percent, 11% from the total people. And we believe that due to the lack of education about sleep, as 62% respond no when we ask them, did you receive education in PT or OT school about sleep? And 85% respond no when we ask them, have you had education about sleep anywhere other than PT school, such as workshop or course? And 85% respond, I don't know how, when I ask them, why do you don't assess your client's sleep habit or quality of sleep? So our PTs and OTs know that sleep is important, but they don't know how to assess that. So that was the main reason behind doing such a presentation, to increase your knowledge about screening for common sleep disorder and how we can assess sleep and later fatigue. So therapists, we now know that therapists should regularly assess overall sleep health and screen for common sleep disorders such as insomnia and sleep apnea. And we can start a line of assessment, such as therapists can start by asking patients general questions that should probe for sleep issue and assess general sleep quality and sleep health. And the information that's gathered from these questions may also lead the therapist to use screening tools for further screening for common sleep disorders. So we create this generic question as a patient interview. We can start asking this question for our patient, and if we feel the answer need further analysis, further investigation, we will go on with further investigation. So we can ask our patient, how much sleep do you typically get? Do you feel well rested when you wake up in the morning? Is your condition impacting your sleep? Is it MS? Is it BD that make your sleep bad? Or is it something related to family issue or something in your life, newly in your life, other than the disease? So we can ask also, how would you rate your sleep quality, poor or good? Does being sleepy during the day interfere with your daily function? While you're reading a book or while you are driving? Do you feel sleepy? Do you have difficulty falling asleep, difficulty returning to sleep if you wake up in the middle of the night, or difficulty with waking up too early? This is a possible indicator for sleep insomnia if it lasts more than 3 months. So if the answer yes, we can do further investigation. And also we can ask, do you snore loudly or frequently? Has anyone observed you stop breathing while you sleep? And this is a possible indicator for obstructive sleep apnea. So after finishing this question, we gather our information, and if we feel that our patient is at risk of sleep disorder, we can refer him to physician, and we can do a quick screening using quick screening tool to assess the risk of sleep disorders. Now we will give examples about the screening tools that we might use in our clinic. It's something easy to administer for our patient. First of all, we will talk about specific sleep disorder screening tools, such as if we need to screen, for example, for insomnia, what we need to use. So insomnia, again, I will repeat the definition so you will remember. It's a difficulty falling asleep, maintaining sleep, or waking up too early at least 3 nights a week for 3 months. We usually use to assess that a screening tool called Insomnia Severity Index. It consists of 7 questions. The score is range between 0 and 28, with more than 10 suggesting a clinical insomnia. For obstructive sleep apnea, which defined as recurrent episode of airway blockage during sleep, which leads to decreased oxygen saturation and increased effort to breathe, we can use a screening tool called Stop Bang Questionnaire, which consists of 8 questions. scored based on yes or no basis. It's if 3 or more items are answered yes, the person is at risk of developing obstructive sleep apnea. Now, this is a disease specific and sleep disorder specific, but now we can use something generalized, like to assess sleep quality in general. So there is a well-known questionnaire called Pittsburgh Sleep Quality Index. It assesses sleep quality, consists of 19 items. Higher score indicates poor sleep quality with a cut point of 5, can differentiate poor sleeper and good sleep quality. The second one is called Epnorth Sleepiness Scale. It assesses the daytime sleepiness. It's a questionnaire, consists of 80 questions with higher score indicate a higher level of daytime sleepiness. Score more than 10 indicate excessive daytime sleepiness. All the questionnaire and the screening tool we mentioned are translated and validated in Arabic language. And if any of you would like to have them, we will be happy to provide you with these questionnaires. Now, these questionnaires are called the subjective assessment of sleep. So if we feel from the patient's answer that we need further analysis, we need more investigation, such as if we feel really our patient has obstructive sleep apnea, we can't just stop here. We need to do objective assessment of sleep. We need to refer our patient to sleep specialist to do an objective assessment. The gold standard assessment for sleep is called polysomnography, which is the sleep study or the sleep lab study, where the patients go to a hospital or a private center or even hotel that's occupied by this polysomnography, and it records brain waves, oxygen level in the blood, and heart rate and breathing, eye and leg movement during the study, and give us the status of the patient sleep. So this is the most objective or the gold standard for assessing sleep. It's expensive way to assess sleep. I believe 1 night of polysomnography, it costs in Jordan 450 JD, 1 night. And usually we need more than 1 night in sleep studies. Now, fortunately, we have a cheaper method to objectively assess sleep, which is called Actigraph or ActiWatch. It's a portable device, recording movement over extended period of time, usually used in extensive manner in sleep studies. And many studies have correlate the results from Actigraph with the results from the gold standard, the polysomnography. Usually, we ask our participants to wear this Actigraph for a period of 1 week or 2 weeks, and we analyze the data from that, which gives us information about sleep quality, quantity, how many hours, if there is sleep, and information about sleep efficiency, the waking during the night, which give us insight about if sleep is fragmented or not. So these are the objective and the subjective measures of sleep. So we start line of questions, then we move to the subjective assessment of sleep. If we feel we need advanced method of sleep assessment, we refer to the objective assessment of sleep. So now we decided there is a problem in sleep, so we need to move on to sleep management. We start our line of management through sleep hygiene education. So therapists should provide instruction about ways patients can optimize their health or their sleep health. That's the primary method to facilitate sleep health, would be to educate patients about good sleep hygiene practices. And we have a set of instruction and examples about sleep hygiene and how we can improve our sleep quality. It might be logic for some of you. We usually ask our patient to go to sleep and wake up at the same time every day. And we ask them not work or watch in the bed. Bed is for sleeping, not for doing these activities. So we can do these activities outside the bedroom. Keep the bedroom for sleeping. and avoid moderate to vigorous exercise at least 2 to 3 hours before bedtime. Studies have shown that the best exercise timing to improve sleep quality during the morning time. However, if this is impossible for work circumstances, we can just keep 2 to 3 hours before going to bedtime. And as you know, avoid caffeinated food and drink at least 4 hours before bedtime. Well, the last thing is don't take unprescribed over-the-counter sleeping pills because it might lead to, you will get addicted to that, and after time, they will not benefit you at all. So this is the first thing, which is education and sleep hygiene. And also we can have patient education about positioning for sleep and addressing bed mobility. And a study have published by Dr. Mays on 2017 give us like instruction or suggestion how patients can improve their sleep through the bed mobility and the positioning during the sleep. So therapists should consider educating patients about appropriate positioning for sleep, considering the patient diagnosis as well as addressing impaired bed mobility if needed. We can educate our patient to sleep in a pain-free or pain-reduced position that may lead to limit sleep disruption for our patients. And we come up now for the third line of management, which is exercise. Acute and chronic exercise has a moderate positive benefit on sleep characteristics in healthy, middle-aged, and older adults. And also, exercise have shown that or studies have shown that exercise significantly improves the sleep for people with chronic insomnia. And also a recent study, an individual with MS who participated in moderate intensity aerobic exercise program and low intensity walking and stretching program have shown improved sleep quality. Also, recently we have published a study about the effect of aerobic exercise on sleep quality measures and sleep-related individual individual with multiple sclerosis. It was a randomized controlled trial. We asked our participants, MS participants, to come to our clinic in Just University and do aerobic exercise 3 times a week for 3 weeks. And we have found that exercise may be a non-pharmacological, inexpensive, and safe method to improve sleep quality in people with MS. Also, we found interesting findings that might explain this mechanism that make the sleep quality improve. We found that after aerobic exercise, serotonin level improve. So there is improvement in serotonin level. And if you remember this presentation, Dr. May said that one of the biomarkers or mechanisms that enhance sleep quality is serotonin. So exercise is very important to improve sleep quality. Another research that have been conducted on Jordan University, Dr. Mays was one of the teams that supervised this study. So I will let her take the lead and talk about the promising results of this study. Dr. Mays?
Yes, thank you. So the evidence that I will share with you now is from still an ongoing study in the Cell Therapy Center at the University of Jordan, where the aim of the study was to look at the effect of stem cell therapies, specifically mesenchymal cells, and a combined exercise program on a variety of symptoms. One of them was looking at this effect of therapy on sleep quality. This is just preliminary analysis on 36 individuals with an average age of 34 and mild disease severity. These individuals were randomized into one of 3 groups. The first group performed a 6-month combined exercise program. Specifically, the exercise program was a combination of aerobic training on a recombinant stepper, resistance exercises, and a balance training program. And it was a supervised 6 months, 2 times per week. The other group received only the stem cells or the mesenchymal injection injections, while the third group received both lines of therapy, the combined exercise and the mesenchymal cells. And I'm just going to share with you this graph. We looked and measured sleep quality using the Pittsburgh, which is the assessment that Dr. Ilham just talked about in a minute. And as you can see, the exercise group has actually, and also the other group that performed the combined therapy had positive, let's say, changes in their sleep compared to the group that only received the mesenchymal injections. It is very early to draw conclusions, but it seems that exercise is playing some sort of a role in having those positive effects. The other results were on the Epworth Sleepiness Scale, which measures daytime sleepiness. And as we can see, all three groups have actually improved 6 months after the baseline assessment. However, those who performed only the exercises seem to have the most positive benefits. Again, this is just preliminary, but those results are promising that I wanted to share with all of you. So other management interventions for sleep that have been shown to improve sleep quality might include some cognitive behavioral strategies and cognitive restructuring techniques, like cognitive behavioral therapy, which is a psychosocial intervention that aims to improve mental health and help to treat problems like sleep. Increasing coping skills, stress management, time management interventions might also help to improve sleep. If the patient have sensory disorders, teaching self-management, addressing these issues, sometimes management for the caregiver himself can also improve the sleep quality. Modifying the environment, and I think Dr. Ilham touched base a little bit on this, including the light in the room, having the temperature in the room where the patient sleeps is very important. It has to be comfortable, the bedding, the pillow, the whole area where the patient is sleeping, and use of technology. We all know that the blue light that is emitted from iPads, tablets, phones, and TV screens definitely interferes with the circadian rhythms or the biological clock of the individual, and definitely impacts their sleep. And I want here to highlight because in speaking of environment, for all of you who works in hospital settings, there's a lot of evidence that shows, unfortunately, hospitalized patients having a poor sleep quality. And it is probably because of the complications of the, for example, the medications they take during their hospital stay, the medical interventions, or for example, the surgeries that they have that might increase their pain and disrupts their sleep, and also the environment, the hospital environment itself. For example, if they are mostly in the room where there are other patients, the visitors that might come at night, the nurse shifts that come and wake them up during the night to take their medication, or take them to have an X-ray or an MRI, the light from the room. All these factors, unfortunately, disrupt the sleep quality of hospitalized patients. So this is something worth notice. Also, addressing the secondary conditions. We all know that looking at what are the aggravating factors of a problem help you plan what to address in your management. So, for example, if the patient has pain, decreased range of motion, and if they have fatigue, they definitely should address these issues, and this will indirectly improve their sleep quality. So, in speaking of fatigue, now we're going to go through how you can assess fatigue and what are the management options. As I mentioned earlier, fatigue is very complex, and I think I've shown that with the many classifications and the different factors. So it is very difficult to objectively quantify fatigue. Yes, there have been attempts to objectively quantify it. through by trying to measure the concept of fatigability. If you remember, I said it is the deterioration of muscle performance or mental function over a period of time. So there have been previous attempts where we might ask the patient to do, for example, using a handheld dynamometer, doing grip strength for a specified number of repetitions, and then looking at the deterioration of muscle force throughout these 15 repetitions, for example. These are just attempts, but there is no gold standard objective measure of fatigue. So commonly, it is assessed using self-reported scales. Those self-reported scales can give you like a total score of how fatigued your patient is in the past 2 weeks, in the past month, or in general, or it might give you a score of the different aspects of fatigue, like cognitive and physical. In front of you in this table are common screening tools that you can use on various neurologic conditions. There are some validated fatigue scales that are specific for populations. For example, we have the Parkinson's disease fatigue scale, or a scale specific for MS. So I just wanted to share with you the ones that you can use with various neurologic populations. So the first one is the fatigue severity scale. It is a very quick screening tool to assess fatigue. It's only 9 items that measures the severity of fatigue and its impact on the individual's activities and lifestyle. A higher score on this scale means that there is higher fatigue severity. Usually the highest or the maximum score an individual can have is 63, and the lowest is 9. And again, it can be used with a variety of neurologic conditions. The other one is the modified fatigue impact scale. Although it's mostly and commonly used with people with MS, but it can be used with other populations. However, it's mostly recommended for use in MS individuals. It's 21 items, and the good thing about this scale is that you can further have sub scores of different components of fatigue, including physical, cognitive, and psychosocial. And similar to the fatigue severity scale, a higher score usually indicates greater levels of perceived fatigue. So if we talk now about the management, again, due to its complexity, there is lack of consensus on what is the best treatment approach of fatigue. But I think you can actually, after understanding about the etiology, especially, we can't change the disease process itself, and we can't treat the condition, but we can have an impact on the secondary factors like pain, like sleep quality. There is evidence that shows using sleep hygiene education actually improves or decreases fatigue in neurologic conditions. So management usually starts actually by educating the patient about the symptom. It is not only overlooked by clinicians mostly, but also sometimes can be ignored by the patients themselves. They do not understand the impact of this symptom on their quality of life and their functioning. So this is the first line of management. Just educate the patient, and sometimes, most importantly, educate the family, educate the caregiver. Unfortunately, I'm just going to give you an example. In people with MS, sometimes people, like the community, perceive disability meaning somebody is using a wheelchair. That's it. So a lot of MS patients suffer from fatigue. It actually really interferes with their daily function. So if they have like a handicap sign and they drove and parked in the handicap sign and they got off the car, they're walking, they're fine. People might stare at them. Why did you take the spot? But it is disabling. So education is the first line of treatment. There are both pharmacological and non-pharmacological interventions used for fatigue management. management. And of course, we're just going to highlight the non-pharmacological approaches. This might include physical activity programs. So we're talking here about exercises like aerobic and resistance training, flexibility exercises, aquatic therapy, doing exercises in the pool, some more low-key or low-intensity exercises like yoga and Tai Chi. And I'm going to talk about it in a minute in terms of is it really beneficial or not. We have other forms of treatment like behavioral management techniques, cognitive behavioral therapy, and what we call mindfulness therapy, which is similar to cognitive behavioral therapy. It's a psychosocial kind of intervention together with meditative practices that has been used before to manage fatigue, educational and self-management programs. So you educate your patient not only on acknowledging this symptom, but also on using, for example, techniques like relaxation techniques, improved sleep hygiene, as I mentioned earlier, avoid multitasking, prioritizing, for example, knowing that the fatigue, for example, in people with MS is worse in the afternoon, tell your patient simply to do most of the activities of the day like early in the morning. This is part of the self-management educational program. Also, another line of treatment that have been used before include physical modalities like cooling therapy, pulsed electromagnetic devices, and light therapy. And I'm going to talk about the evidence in a minute. And there is also alternative therapies like acupuncture, visual imagery techniques, and other kind of alternative therapies as well. So if you look at the evidence from all these management interventions, we can divide them into either they are high quality evidence versus moderate or versus weak or low quality evidence. And this is based on the fact that how many studies have been made on these populations, what are the psychometric properties, and if the study design is strong, and it has been done on a large number of patients, etc. There's something unfortunate about the evidence out there on fatigue is that most of the management interventions have been performed on people with MS. So you will find the high quality studies only on people with MS compared to other conditions. And this is probably due to the prevalence of this symptom in this population and its impact on their life. But that doesn't mean that it is less important in other conditions, but of course, more studies and strong RCTs are needed in other populations. So the high quality evidence in people with MS includes physical therapy interventions, mainly aerobic exercises and other physical activities that includes resistance and flexibility exercises. The recommendation for people with MS in terms of exercise to decrease their fatigue and improve their quality of life include that they have to do moderate aerobic exercise at least 2 times per week, and also do moderate intensity resistance training at least 2 times per week in order for them to maintain proper functioning and less fatigue. We also looked at there is high quality evidence regarding psychological and educational interventions, including the management options that I've just mentioned, like educating your patient on prioritizing their tasks, manage the other symptoms, for example, sleep hygiene education, etc., and psychological interventions like cognitive behavioral therapy and mindfulness therapy, energy conservation interventions, including the education, the self-care, communication, working on the patient's biomechanics, and also environmental modification regarding the factors that we mentioned earlier, the light, the temperature, the noise, etc. If you look at the moderate quality evidence, here there's a mixed kind of interference between other populations. We find that there is some moderate quality evidence regarding multidisciplinary rehabilitation that has been found effective in minimizing fatigue. When I say multidisciplinary rehab, I'm talking about the coordinated delivery of interventions by 2 or more disciplines, including nursing, physiotherapy, occupational therapy, of course, social work, psychology, etc. It is often why it is let's say recommended sometimes, because it is often individualized to the needs of the patients in terms of various factors that the different disciplines and can bring their expertise and skills for the variety of symptoms that the patients have. But specifically for fatigue, yes, it has been found to be effective, but there is moderate evidence on that. Home-based physical activities in stroke patients and TBI can be effective. Aquatic therapy in people with MS and traumatic brain injury patients have been found to be effective, but again, not a lot of studies. Group educational programs done face-to-face or even online, including self-management in stroke patients and TBI, have been found to be effective. And mindfulness therapy that has been used with stroke and TBI patients is effective, but again, we can classify them as being moderate quality evidence. If we look at the low quality evidence, this includes the activities like yoga, Tai Chi, cooling therapies like garments and using cooling aids, pulsed electromagnetic devices, using light therapy, biofeedback treatments. All these in various populations have been found sometimes being inconsistent results, and sometimes often not significant, and we can't compare them to other interventions because they have low quality evidence. So to summarize our webinar for today, it seems that you as a neurorehabilitation specialist have much opportunity to play an active role in providing sleep health education and manage fatigue among your patients. You will help your patients to reduce the risk of developing sleep disorders that might make their condition even worse, reduce the effects of chronic fatigue, potentially reduce the onset of even chronic conditions and worsening of other symptoms. And by helping your patients managing their sleep problems and fatigue, you are promoting sleep health and active lifestyle because you are incorporating physical activity and exercise among your patients. So thank you, and sleep well tonight, and we are happy to answer your questions.
Thank you, Dr. Mays.
Thank you, Dr. Ilham, and thank you, Dr. Mais, for this very informative presentation and very helpful. Thank you so much. I think there are many questions in the chat area. If you can go through them. So I think the first question was, what is the normal time for NREM and REM?
Okay, the normal time for non-rapid eye movement and rapid eye movement. That's a nice question. Here I would like to highlight the circadian rhythm, where your body will ask you to go sleep. So usually your body mechanism asks you to go sleep, whereas your tiredness starts to collect itself, and melatonin will be secret in the body, telling your body that you have to shut down. This is what we call a circadian rhythm. This happens between 9 and 10 p.m., whereas really you need to go to a bedroom. And there is, as I mentioned, a timeline where you can get the deep sleep starting from where you get to sleep, where you go to bed. Like if you go to like 10 p.m., you will get the deep sleep, which is 4 hours or 3 hours from your sleeping time. So 9-10 p.m., it's the circadian time for your sleeping, which is, I don't think so anybody will get that.
Not any more.
Not
time.
me.
Yeah. So but what about the duration? The duration of that cycle?
As I mentioned, it's 90 minutes, 90 to 110. This is the cycle. Whereas REM sleep and non-REM sleep alternate. However, during the same cycle, as I mentioned in general, non-REM sleep. However, during the first half of the night, slow wave sleep is prevalent, even though we go through REM, but it's more prevalent. So if we go through the non-REM sleep, you will spend most of your time slow wave sleep, the deep sleep. But the cycle, it's 90 minutes.
So is there any variation between patients, like, for example, students, graduate students who have difficulty sleeping, or patients?
Yes, sure.
Do they have variations in these dysfunctions between like different patients groups?
Yes, there is variation between even young individuals, young individuals who are students, who always get bad sleep quality because of the exams and studying all the night. And there is many published study about different population, disease population. Each study for MS, PD, they characterize sleep characteristics for each of these cycles. And how many time about sleep quality, quantity, tons of study that characterizes sleep quality in each of these population. Your specific question about students?
Probably. I mean, the classification of the cycle itself and the division of the cycle.
Yes,
yes.
yes.
I mean, like you see in patients like in patients like with MS. Do you see variations in non-rapid or rapid eye movement? Or
there is. Now, I will tell you about, for example, older individuals. In older individuals, if you get old, you will have much more, like 60%, 50 to 60% of your night is stage 1 and stage 2, which is the shallow sleeping. Tamam? So the slow wave sleep decrease, and the rapid eye movement also decrease. That's lead us to, I'll give you example just in older individuals. So there is a sleep structure. Their sleep structure is changed just because they get old. We call this age-related changes in sleep structure. But you know, what's the difficult thing here? That we need sleep lab. Nothing give you this information except the sleep lab. So you need the most expensive way to know that. But there is a lot of studies have been done on different sleep population. Do you know, Dr. Mais, if there is any on young individuals?
Yes, I can add that the problem that might arise is that if somebody have poor sleep quality, which is chronic, there are different kind of sleep disorders, like we can't kind of mention them all, but for example, there's a specific line or an umbrella term of disorders called circadian rhythm disorders, in which people might have really altered ratios of different sleep stages because of various factors. It could be something physiological, or could be basically just because of bad habits that led to having poor sleep quality. In general, from the time of infancy until, as Dr. Ilham said, until somebody is older adult, yes, the sleep structure changes all the time. What we represented today is the normal for an adult to go from 90 to 110. However, there are certain, yes, sleep disorders and bad sleeping habits that might interfere with the structure and of the sleep. And another problem that might arise is what we call night-to-night sleep variability. If someone sleep every night differently, that definitely will affect their sleep structure, because you need to have those 4 to 5 cycles every night. So if one night you are sleep deprived and the other night you're not, you're kind of missing out the importance of having this rhythm routinely. That's why one of the sleep hygiene education tips is that you go to your bed and wake up on the same time every day and night, so that you have those full cycles without messing up the structure and the ratio of these factors.
And this leads me to another question. Let's say we analyze that and we send the patient to a sleep analysis, a sleep lab.
Yes.
So so as a clinician, as an OT, as a PT, what does that make a difference? You know, the analysis, the result of this. does these variation like affect my suggestions and tips for this patient?
So as a neurorehabilitation specialist, you're not going to really interfere with the like the assessment on using polysomnography or the sleep lab, but it will help your patient to have a diagnosis. So as Dr. Ilham mentioned in part of the assessment, you can help your patient first by highlighting that there is something wrong when you screen for having a sleep problem, and by asking the prompt questions that might show that there's an underlying issue like insomnia or obstructive sleep apnea. You further screen for that, and if it's actually your patient is risky, now they have to have an official diagnosis. It's important to highlight that polysomnography is important for diagnosing these common sleep disorders. Having a screening tool will only give you if the patient is have a high risk or not. But having a diagnosis, they have to go to a sleep specialist and have a sleep lab assessment, and then get the diagnosis to get the appropriate treatment. Obstructive sleep apnea is very dangerous. It is not only treated, you are part of the management, but you are not the only management. They have to have medications in order, like the CPAP or other types of medications to help them actually overcome this problem. So you are helping by diagnosing these issues.
Okay, can I add something?
Oh, go ahead.
Go back again to the sleep apnea example that Dr. Mais mentioned. If our patient have sleep apnea, as also she mentioned, it's a very dangerous condition. This might interrupt your motor learning, and you need to treat that. You need to refer that to for a sleep physician who can treat the patient, because there's many studies have done and give us evidence that it interrupts your sleep, your motor learning. So there is no offline motor learning. The beneficial effect on motor learning will not happen. So we need to treat that. Again, there is a lot of evidence is coming now telling us that we can help as a physical therapist and occupational therapist. I'm not sure the quality of evidence because it's newly studied. We need more studies to be done, but exercise can benefit. Exercise can be a beneficial route of intervention to help people with sleep apnea. And one of the slides that we present tell us about insomnia and the effect of aerobic exercise on improving the insomnia symptoms for our patients.
Someone is asking about slide number 22. Can you please repeat that or go over it again?
22. Okay, what's the specific question? This slide is talk about the procedural memory formation. So if you are learning a new task, you will go through the memory to have a memory inside your brain about this task. It will go through specific stages. There are 4 stages: the encoding, consolidation, storage, and recall. The encoding is the first stage. We call it online stage because we still working with the task. We engage with the task. So it's where your participants engage with the task and perform the action. So successful acquisition results in attaining certain level of task proficiency. So let me give example. If you are learning how to drive, you enroll in driving lessons or whatever, and in the first session, you start to engage with the car, with the steering, with different parts of the car. So you end the session with a certain level of a proficiency. And this leads to perform a memory representation in the brain. All right. So you go back home. If you sleep, you will get beneficial effect of sleep. Like you go to the consolidation, where is the brain organize the memory about driving, put it in right traces, so you will not forget about driving. This is what we call consolidation. It's the conversion that happens to the memory traces from pliable stage, where we can forget it, where we can lose it, into more permanent case. Then after consolidation, it is we store that in our brain, and we recall it for another use using the last stage, which is the recalling. Is there any specific question about it?
Okay.
As I mentioned here, that sleep affects each stage, but the most stage that really studies have studied it's the consolidation, and we as a group in Just University have done like 3-4 studies about encoding.
Okay, this should do it. Are the two types of fatigue classified only in MS disease?
Okay, so I think the question is about cognitive versus motor fatigue. So it's mostly used to classify fatigue in people with MS. But however, yes, that doesn't mean that, as I mentioned in the presentation, that patients with stroke can complain about having physical fatigue. TBI patients can also have problems with cognitive fatigue. So the short answer is no, it is not just specific for people with MS, but it is generally used to classify that in MS because how it's very, let's say, prevalent in this condition.
Okay, smartwatches, can they, especially the contains sleep analysis, are they reliable?
Yeah, this is a very, very good question, and not only for smartwatches, but there's a lot of sleep apps that are used in the phone, like, I don't know, 500 something I once read in an article. Let's start with the good part. The good part about using these sleep trackers is that it actually gives you something to reflect on. So you can use it with your patient to help your patient, for example, recognize their patterns of their sleep habits. So part of self-management and education. But when it comes to reliability and validation, unfortunately, I think all of the sleep trackers out there, they are not validated with the gold standard objective measures of sleep, which is polysomnography. So that does not make it a lot reliable in terms of the results. However, it can be used to give kind of a feedback mechanism to your patient about what their sleep habits is, but it is not actually been validated.
Thank you. I'm not sure about which questionnaire Shada is talking about, but questionnaire can be used with pediatric clients.
Yeah.
I think she is it the Pittsburgh or?
I'm not sure.
Okay.
So what about these questionnaires? Can they be used with pediatric population?
It's very good. There's been actually a recent study that looked at the use of sleep assessment in pediatric patients. Unfortunately, there's been not a lot of assessments that has been validated in children. There are a couple of ones that has been specifically developed for children. One of them is the Children's Report of Sleep Patterns. So this one can be used. However, it does not have a lot of strong psychometric properties. In terms of the ones that we explained, which is the Pittsburgh and the Epworth, unfortunately no psychometric reports in children, but there are a couple of ones that can be used. If you don't have that sort of an assessment, just by knowing the recommended time hours so in terms of sleep duration for children's and infancy, and just by having an interview like with the parents about what are their sleeping habits, their lifestyle factors, the environment, this can prompt at least and help you to highlight if there is a problem. Other questions?
If you just read the Pittsburgh, you will tell that it's not probable for.
Okay, so Ataf has a smartwatch which have a sleep analysis program. I don't know which type, but she wants to know what is the normal duration for light and deep sleep.
Light and
light,
deep.
Light sleep and deep sleep.
So let's for a healthy adult, you spend around like 13 to 20% of your total sleep time in deep sleep. So deep sleep is the like the lowest percentage compared as a ratio. If that's, I think, what she wants to know. So for example, if you sleep 8 hours per night, roughly you will spend 60 to like 110 minutes, 1 hour and 10 minutes, almost 2 hours, sorry, in deep sleep compared to light sleep.
Okay, what's your take on hypnosis therapy? And what's your opinion about that? They say that 15 minutes of hypnosis equals 3 hours of sleeping. I'm not sure where that, but
any evidence, Mace, about
so
hypnosis?
hypnosis is actually goes under the low quality evidence therapy, similar to acupuncture and imagery and these types of therapies. It's low quality. There's not a lot of research on this. Even the research that has been used, it's very inconsistent. So it is not really reliable to rely on this only type of management.
So if you just show your email at the end, so attendees who wants to really get in contact with you, we'll try our best to provide the slides and the recorded webinars to everybody. Last call for you, Dr. Ilham and Dr. Mais, if you want to say the last anything at the end, okay?
So thank you so much, Dr. Muhammad, for this opportunity to give our talk. Thank you for our audience. I hope you will get your expectation out of this presentation. Any help about any sleep and fatigue issue, we will be happy to help. Any training on the assessment tool we offer in this presentation, we will happy to do. Thanks for your time, and I hope you will be fine. Sleep well and stay home. Thank you so much.
Yes, thank you so much for your attendance, and I can.
Assalamu alaikum wa rahmatullahi wa barakatuh.